Extract 1. Questions 1 to 12. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
You hear a doctor talking to a patient.
Hello, doctor. Good morning.
Yes, good morning. What can I help you with today?
Doctor, I'm getting a throbbing pain in my right shoulder.
How long have you been experiencing this pain?
For the past 5 months. But the pain has worsened in the last 2 months. The pain aggravates as I'm a regular baseball player that involves throwing. Now I am also participating in basketball.
What is your age?
21.
Oh, I see. Do you take any medication?
I was taking non-steroidal anti-inflammatory drugs and muscle relaxant medications.
Are you allergic to any medicines?
No, doctor.
Have you had any surgery or any diseases?
No.
Do any of your family members have any diseases?
Yes, my mother has arthritis.
Do you drink or smoke?
No, doctor.
Well, your blood pressure is 116/68, respiratory rate 16, heart rate is 68, and weight 165 pounds. Your right shoulder shows evidence of swelling and tenderness. Radial pulses are 2/4. Bilateral. Brachial pulses are 2/4. Bilateral. Range of motion of your right shoulder shows decreased flexion, decreased extension, decreased adduction, decreased internal rotation, decreased external rotation. Left shoulder is normal. External rotation is fair. Internal rotation is poor. Rotator cuff impingement is moderate. Your X-ray report reveals presence of cuff arthropathy. You have developed rotator cuff syndrome in your right shoulder. Actually, the rotator cuff is a group of muscles and tendons surrounding the shoulder joint. A rotator cuff injury causes a dull pain in the shoulder and often worsens when you try to sleep on that side. Often, rotator cuff injuries occur in people who perform overhead motions repeatedly in their jobs or sports. Without treatment, rotator cuff injuries may result in permanent loss of motion or weakness, which may result in progressive degeneration of the shoulder joint. Although resting your shoulder is essential for the recovery, keeping the shoulder immobilized for a long duration can cause the connective tissue to become thickened and tight, a condition called frozen shoulder. I am prescribing you Vioxx 25 mg tablet once per day. I am giving you an injection to your shoulder joint with Celestone Solispan 1.0 cc. If the condition is not improved within 15 days, then I would order an arthroscopic tendon repair in which a tiny arthroscope and tools are inserted through small incisions to reattach the torn tendon to the bone. That is the end of Part A. Now look at Part B.
Extract 2. Questions 13 to 24. For questions 13 to 24, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
You hear a doctor talking to a patient.
Hello, doctor. Good morning.
Good morning. May I know your problem?
Well, when I was walking into a store yesterday, I felt dizzy and had some cold sweats, some shortness of breath, but there was no chest pain, nausea, or vomiting. I suddenly sat down and lost consciousness for a minute or so. However, there wasn't any tonic-clonic movements.
What's your age?
48.
Did you had any cyanosis, which means that the skin goes bluish?
No, doctor. Then I got up on my own, and even now I'm having mild shortness of breath upon exertion. This is totally unusual for me, doctor.
Do you have any fever or syncopal episodes?
No, doctor.
Have you had any diseases or surgery in the past?
Well, a year ago, pulmonary embolism was diagnosed. But during that time, I had an IVC filter placed due to massive gastrointestinal bleeding diverticulosis and gastric ulcers, paroxysmal atrial fibrillation, and no anticoagulation due to history of gastrointestinal bleed. Coronary artery disease status was post-bypass graft surgery at that time. I had to stay in the ICU for 3 weeks due to lower GI bleed again.
Okay. What medications are you taking now?
Aspirin, potassium, Lasix, levothyroxine, lisinopril, Pacerone, Protonix, Toprol, vitamin B, Zetia, Zyrtec.
Are you allergic to any medicines?
Yes, to sulfa.
Well, your blood pressure is 155/57. Pulse rate is 61. Respiration's 18, and oxygen saturation is 95% on room air. No lymph nodes or masses. No lower extremity edema. No redness or hotness. The laboratory reports show creatine 2.1 and hemoglobin 9.6. Your chest X-ray is clear. You have developed pulmonary embolism with contraindication to anticoagulation due to recurrent gastrointestinal bleed. Status post-IVC filter. You have also developed mitral valve disease, coronary artery disease, and peripheral vascular disease per cardiology. No evidence of chronic thromboembolic disease per VQ scan. We cannot rule out pulmonary hypertension. Shortness of breath upon exertion. You will need a pulmonary function test as an outpatient. I will do oxygen saturation with ambulation to prevent it causing loss of consciousness. Part B. In this part of the test, you will hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B, or C, which best fits according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio. Now look at question 25. You hear a discussion between a physician and nurse explaining about schistosomiasis and its causes. Now read the question.
Hello, doctor. What is schistosomiasis, and what are its causes?
Schistosomiasis, also termed as bilharzia, is caused by parasitic worms. Although these worms are not found in the U.S., more than 200 million people are affected worldwide by this disease. In terms of impact, this disease stands next to malaria as the most devastating parasitic disease. Schistosomiasis is also considered one of the neglected tropical diseases. The parasites causing schistosomiasis dwell in certain types of freshwater snails. The infectious form of the parasite, known as Cercariae, emerge from the snail, therefore contaminating water. Most human infections are caused by Schistosoma mansoni, S. japonicum, or S. hematobium. One can become infected when the skin is exposed to contaminated fresh water. Question 26. You hear a discussion between 2 doctors about the importance of measuring serum amylase or serum lipase. Now read the question.
Doctor, can you explain to me whether measuring serum amylase or serum lipase is significant for acute pancreatitis?
Well, measuring both serum lipase and serum amylase is not necessary. Measuring serum lipase alone is adequate for diagnosing acute pancreatitis, since it is more effective than serum amylase, especially because it rises more quickly and remains elevated longer. According to a study of 151 patients with acute pancreatitis, the sensitivity of lipase was about 97% and the specificity was almost 100%. Contrarily, the sensitivity of amylase was just 79% and the specificity was 99%. Therefore, amylase should be replaced by lipase as the first-line laboratory investigation for suspected acute pancreatitis. Question 27. You hear a discussion between 2 doctors about the misdiagnosing of acute cardiorenal syndrome as renal injury due to hypovolemia. Now, read the question.
Hello, doctor. What is your opinion about misdiagnosing of acute cardiorenal syndrome as renal injury due to hypovolemia?
Often, acute cardiorenal syndrome is misdiagnosed for renal injury due to hypovolemia. Patients with stable heart failure normally have mild hypervolemia at baseline. However, they can become hypovolemic due to severe diarrhea, over-aggressive diuretic therapy, or other causes. Although the fluid status of these two conditions are different, they are often difficult to distinguish. Urine electrolytes suggest a pre-renal acute kidney injury in both of these conditions. However, a history of recent diuretic overuse or recent fluid losses may help identify hypovolemia. If available, analyzing of the recent trend in weight will be essential in making the right diagnosis. Misdiagnosis of acute cardiorenal syndrome as hypovolemia-induced acute kidney injury will be catastrophic. In case the volume depletion in acute cardiorenal syndrome is erroneously judged to be the cause of acute renal injury. Therefore, fluid administration can further worsen both renal and cardiac function. Question 28. You hear a physician explaining to his nurse about sepsis and infection. Now read the question.
Doctor, what is sepsis?
Sepsis is the extreme response from our body to an infection. This is a life-threatening condition, and without timely treatment, sepsis can rapidly cause tissue damage, organ failure, and mortality. This happens when an individual already has an infection in his lungs, skin, urinary tract, or somewhere else, triggering a chain reaction throughout the body. 4 types of infection that are often connected with sepsis are lungs, kidney, skin and gut, and the most frequently identified germs that cause infections and can develop into sepsis include Staphylococcus aureus or staph, Escherichia coli, and certain types of Streptococcus. An infection occurs when germs enter into the body and multiply, causing illness, organ and tissue damage, or disease. In case that infection grows aggressively, resulting in a life-threatening condition, is called sepsis. Question 29. You hear a discussion between 2 doctors about brain imaging prior to lumbar puncture in the suspected cases of bacterial meningitis. Now read the question.
Hello, doctor. Can you please explain to me when the brain should start the imaging precede lumbar puncture in the suspected cases of bacterial meningitis?
For the patients with immunodeficiency or focal neurologic deficits, or with altered mental status or seizures in the past 7 days, A brain imaging should be performed prior to lumbar puncture. Moreover, corticosteroid therapy and empiric antibiotic should be started immediately after lumbar puncture without waiting for the results. Brain imaging should precede lumbar puncture in patients with focal neurologic deficits or immunodeficiency, or with altered mental status or seizures during the previous week. However, lumbar puncture can be safely done in most patients without first obtaining brain imaging. In case the lumbar puncture is to be delayed, then these treatments should be started immediately after obtaining the blood culture report. Question 30. You hear a monologue by a physician about managing aneurysmal subarachnoid hemorrhage. Now read the question. Managing aneurysmal subarachnoid hemorrhage. Patients with aneurysmal subarachnoid hemorrhage are at high risk of complications such as delayed cerebral ischemia, rebleeding, cerebral infarction, and mortality. The main symptom is the abrupt onset of severe headaches. When this condition is suspected, a tomography without contrast should be performed. However, positive outcomes are seen when patients are managed in a high-volume center with a specialized neurointensive care unit. Early aneurysm repair by surgical clipping or endovascular coiling is the best strategy to reduce the risk of rebleeding. Medical and neurologic complications such as increased intracranial pressure, hydrocephalus, seizures, hyponatremia, delayed cerebral ischemia, hypovolemia, and cardiac and pulmonary abnormalities are extremely common. This is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which best fits according to what you hear. Complete the answers as you listen to the audio. Now look at Extract 1. Extract 1. Questions 31 to 36. You hear the doctor's lecture on acute cardiorenal syndrome. You have 90 seconds to read questions 31 to 36. Cardiac and renal function are intricately interdependent, and failure of either of these organs causes injury to the other organ in a vicious cycle of worsening function. We are going to discuss about the acute exacerbation of heart failure or acute cardiorenal syndrome resulting in acute kidney injury, which is a common cause of admission to the intensive care unit. Let us examine the clinical definition, pathophysiology, hemodynamic derangements, clues that help in diagnosing and treatment. Cardiorenal syndromes are a group of interconnected disorders involving the heart and kidneys, which are classified based on whether the problem is acute or chronic, and whether the primary problem is in the heart, called cardiorenal syndrome, the kidneys, called renocardiac syndrome, or another organ, called secondary cardiorenal syndrome. Although the above definitions provide a good general description, there is a necessity of further clarification of the nature of organ dysfunction. Acute renal dysfunction can be unambiguously defined using an akin and rifle classification. Here, akin means acute kidney injury network, and rifle means risk, injury, failure, loss of kidney function, and end-stage kidney disease. On the other hand, acute cardiac dysfunction is an ambiguous term that includes pathophysiologically and clinically distinct conditions. Acute heart failure and cardiogenic shock. Cardiogenic shock is characterized by an abrupt compromise in cardiac pump functioning, resulting in global hypoperfusion that is severe enough to cause systemic organ damage. On the other hand, acute heart failure is defined as gradually or rapidly worsening symptoms and signs of congestive heart failure due to worsening pulmonary or systemic congestion. Hypervolemia is the hallmark of acute heart failure, whereas patients with cardiogenic shock may be hypovolemic or normovolemic. Although cardiac output may be mildly decreased in certain cases of acute heart failure, systemic perfusion is adequate to maintain the organ functioning. However, these two conditions cause renal injury by distinct mechanisms and have entirely different therapeutic implications. Reduced renal perfusion because of renal venous congestion is now considered as the major hemodynamic mechanism of renal injury in acute heart failure. On the other hand, in cardiogenic shock, renal perfusion is reduced due to a critical decrease of cardiac pump function. Therefore, the ideal definition of acute cardiorenal syndrome should describe a distinct pathophysiology of the syndrome and provide distinct therapeutic options that can counteract. Hence, we suggest that renal injury due to cardiogenic shock should not be included in its definition. So, discussion of acute cardiorenal syndrome is limited to renal injury caused by acute heart failure. Multiple mechanisms have been implicated in the pathophysiology of cardiorenal syndrome. Sympathetic hyperactivity is a compensatory mechanism in heart failure and may be aggravated in case cardiac output is further decreased. Its effects include constriction of afferent and efferent arterioles, causing decreased renal perfusion and increased tubular sodium and water reabsorption. Different strategies can be followed to prevent acute cardiorenal syndrome. An optimal outpatient diuretic regimen to avoid hypervolemia is very critical. Patients with advanced congestive heart failure should be monitored thoroughly in dedicated heart failure clinics until their diuretic regimen is optimized. Patients should be advised to get their weight checked periodically and seek medical opinion if they observe any increase in their weight or a decrease in their urine output. Extract 2. Questions 37 to 42. You hear the doctor giving a lecture on anticoagulation therapy for patients with endocarditis. You have 90 seconds to read questions 37 to 42.
Hello, doctor. Can the patients with endocarditis be safely anticoagulated?
Managing anticoagulation in patients with endocarditis needs a personalized approach, using a careful risk-benefit evaluation on a case-by-case basis. There is a lack of high-quality evidence. Therefore, the recommendations also vary according to the clinical condition. Newly diagnosed native valve with endocarditis itself is not an indication of anticoagulation. The question of anticoagulation arises in patients who have a pre-existing or coexisting indication for anticoagulation, such as deep vein thrombosis, atrial fibrillation, pulmonary embolism, or an artificial prosthetic heart valve. The question becomes yet more complex in patients with cerebrovascular complications and a coexistent strong indication for anticoagulation. Earlier studies have suggested a significant risk of cerebral hemorrhage with anticoagulation in patients with native valve endocarditis. Consequently, some experts have expressed skepticism about these findings. Moreover, this skepticism arises from the studies that showed a lower incidence of cerebrovascular complications and smaller vegetation size in patients with prosthetic valve with endocarditis, in which most of the patients received anticoagulation therapy. The mechanism responsible for this effect is considered that the vegetation is an amalgam of destroyed cells, fibrin, and platelets, with anticoagulation preventing the growth and propagation of this aggregation. Some experts are of the view that the incidence of ischemic stroke with hemorrhagic transformation in patients with endocarditis receiving anticoagulation is overestimated. According to this concept, the beneficial effects at least counterbalance the harmful effects of anticoagulation. Moreover, the recent studies have shown that patients on anticoagulation tend to have fewer cerebrovascular complications and smaller vegetations. The studies reveal that not only are the cerebrovascular complications less common in patients who were already on anticoagulation when endocarditis was diagnosed, but also there was no increase in the rate of hemorrhagic lesions. These were all non-randomized studies, and most of the patients had native valve with endocarditis diagnosed at an early stage. Significantly, these studies revealed that there were only beneficial effects of anticoagulation if the patient was receiving warfarin before the diagnosis of endocarditis and initiation of antibiotic therapy. No benefits from anticoagulation were seen once antimicrobial therapy had begun. Therefore, starting anticoagulation and antiplatelet therapy for the sole purpose of stroke prevention is not advised for the patients with newly diagnosed endocarditis. For most of the patients with endocarditis and stroke or suspected stroke, anticoagulation and antiplatelet therapy should be temporarily discontinued. This is a need of careful evaluation, individualized assessment of the patients and the risk factors predisposing the patients to cerebrovascular complications such as large vegetations or very mobile vegetations or causative pathogens such as Candida spp or S. aureus. Therefore, may prompt temporary suspension of antiplatelet and anticoagulation therapy. In case there is a clear pre-existing or coexisting indication for these agents and surgery is not expected, consider continuing anticoagulant and antiplatelet therapy, providing that patients are free from the risk factors described above and suspicion of stroke has been excluded. In case surgery is considered for the patients with a clear pre-existing or coexisting indication for these agents, then a short-acting anticoagulant such as intravenous or low molecular weight heparin can be given as a bridge to surgery. This is the end of Part C. You now have 2 minutes to check your answers.
That is the end of the listening test.